A quick intro from me. I'm Katie Noon. I'm the Chief Operating Officer at Guts UK Charity. For those who aren't familiar, Guts UK is a charity that has been around for more than 50 years, but we're now trying to make our impact and the work we do more widely known. We cover all things to do with digestive conditions and symptoms, right from where it goes in to where it comes out. And we do that through information services and support. We work on raising awareness and public education, a bit like this webinar today, and we fund life-changing research. This evening is an exciting opportunity for Guts UK Charity to try a slightly different approach to raising awareness about one of our rarer digestive conditions. So thank you to the team at Guts, to our speakers that are joining me today, and to Enterra, who have kindly supported in making this possible. Today, we're focused on gastroparesis, and I'm joined by some specialists in the field who will talk through what the condition is, how it can be managed, and what it's really like to live with it. I will be your guide for the session, but they are definitely the experts. We'll host a Q&A at the end of the session. We have the Q&A function open for you to ask questions throughout. We will be moderating those questions just to make sure we don't share anything controversial from a GDPR perspective and because we are recording the session. We're very happy to take questions, but I will caveat that we can't offer individual medical advice in this session. Please pop your questions in throughout. We'll cover them all at the end as best we can. I think that's all of my points covered. We do, however, seem to be missing one of our speakers. So we're going to quickly rejig the order, I think. No, we're not. Thank you. It's my screen. That's why I'm your host. I'm not the expert. So I am particularly thrilled now that we're joined by Dr. Ray Shadwari. Ray is a highly qualified consultant gastroenterologist, comes with a wealth of expertise in gastrointestinal conditions, has authored numerous peer-reviewed publications, and is actively involved in scientific research. So now that I know you're here, I will hand over to you, Ray.
Hello, Katie. Thank you so much. Can you hear me?
We can hear you. Thank you.
Thank God for that, because when I logged in, it said I had to update my software. So anxious IT moments, but where we managed to get through that. So I hope you can all hear me. It's really nice of you to invite me to join you tonight to talk about gastroparesis, which is a subject really close to my heart. And it all began during COVID, when I was involved with a BBC program called the Diagnosis Detectives, during which we discussed in a panel all these really difficult to diagnose conditions. And I happened to come across Judy, who had been undiagnosed for years and years and years. And she'd had intervention at the esophagus, and she had surgical therapy to the esophagus. And as a result, had sustained a vagal nerve injury and had developed gastroparesis. And we investigated her and we proved she had gastroparesis, and we fixed her and we got her better. And the next day, the phone didn't stop ringing. And I was contacted from all over the place, from the UK, from abroad, people desperate to come and see me because they'd been suffering for years and years and years with this hitherto undiagnosed condition. And I suddenly realized that there was a huge need out there to sort of help people with this condition. And I must confess that I think the medical profession really has let gastroparesis patients down, because we haven't really, been able to. It's been really difficult diagnosing the condition and treating it. And since COVID, we've been very busy trying to raise public awareness about this condition, and more importantly, creating a sort of an algorithm for our colleagues to sort of help them A, diagnose, and B, manage this really, really difficult condition. What is gastroparesis? Well, if you look at the stomach from the inside, if you do an endoscopy, your stomach looks normal. And this is the problem. We're used to sort of diagnosing things at endoscopy and seeing that there an ulcer there, and we can tell people, oh, you've got an ulcer, easy to treat. Here's some tablets and you get better. But gastroparesis is very difficult to diagnose because when you look inside the stomach as an endoscopist, the stomach may look normal. But that's only a snapshot of what's going on. What you need to think about is not the snapshot, but the film, the moving picture. And that's where you start to see a difference between patients with gastroparesis as opposed to people who don't have gastroparesis. And gastroparesis is essentially a motility disorder that results in delayed gastric emptying. So when you eat normally, the food enters your stomach, and your stomach's a very active organ that's macerating and blending your food from solid into a mash, into a pulp. And when that doesn't happen, the food sits in the stomach. The stomach produces a lot of acid, and you feel full, you feel nauseous, you get symptoms of reflux, regurgitation, and belch, and have pain and discomfort. Now, not all patients will have all of these symptoms, but there will be a combination of these symptoms, which essentially reflect that individual's response to food entering the stomach. And because it's delayed and it sits there for longer than it should, it creates all these symptoms. And the thing that is most frustrating for patients is that the symptoms come and go. They're never constant. If you have an ulcer, you've got pain in your stomach every day of your every day, every hour, every minute. It hurts, and then the pain goes away when you have treatment. But with gastroparesis, you have variable symptoms. And people try different diets, and they go on these very restrictive diets, and you'll hear more about diets shortly. But sometimes they work, sometimes they don't. And that's really, really frustrating. But what's most frustrating for patients is that it can go undiagnosed for years. And you go and see your GP, you go and see the specialist, you see the surgeon, you see the gastroenterologist, and they tell you, oh, well, I've done the endoscopy, there's nothing there. I've done the CT scan, it's normal. So there can't be anything wrong with you. And that's what's really frustrating for patients, because they feel they're not being listened to, and they feel sometimes they're being told it's all in your mind. You're mad, you're going mad, you're anorexic, you've got an eating disorder. And the patients, when they come to see me and they start telling me their symptoms, and I say to them, I understand you, I understand what you're saying, you've got gastroparesis. It's often a very, very emotional moment, because for years they've been going round and round the garden and no one's been listening to them. No one understands what they're talking about. They have test after test after test, and they're normal. And so they start to doubt themselves. Am I making this up? Is my mind playing tricks on me? But it's not. It's just that it's a very difficult condition to diagnose. And so it's been really, really important, work we've been doing over the last few years to try and characterize this condition a bit more and try and help clinicians diagnose it and treat it better. And if you look at the data, you'll see that at very least, a very, very conservative estimate is that 1% of the population suffer with gastroparesis. That's as many as diabetes mellitus, type 1 diabetes. That's a huge number of people walking around there with symptoms of gastroparesis. Now, they may be mild, they may be intermittent, they may be, they come and go for a few days and a few weeks and disappear, or they may be debilitating, so much so that you stop work, you're housebound, you're sometimes tube fed, and some of our patients spend more than half of the year in hospital, being resuscitated, intravenous drips to correct their electrolytes, nasogastric, feeding, because they're not keeping enough in and they're losing weight and becoming malnourished. So it's very common disorder. What are the causes? So the vast majority, over half of my patients will have an underlying hypermobility syndrome. And Ehlers-Danlos syndrome type 3, or the hypermobile variant, is extremely common in society. If you're sitting in an airport lounge and you look around, you'll see one or two people that are bending over effortlessly, extremely flexible, really stretching out to reach things, can do the flips of probably excelled in sports in their childhood, in their youth, I have Olympians that come and see me with EDS. So EDS is very common and gives you advantages. It helps you excel in sport. The downside of that is that sometimes, particularly if you've had an infection like COVID or gastroenteritis, it can cause your gut to slow down. It can cause your stomach to slow down and stop emptying. It can cause the gastroparesis. And so over half, I would say 60% of my patients are EDS patients. The next biggest group are the diabetics, that particularly the type 1s, although I do see type 2 diabetics. So young people that have been on insulin since birth, that have had diabetes in some funny way affect their nerves in a way that affects the nerves going to the stomach and causes diabetic gastroparesis. And they often come, it makes their diabetes a lot more difficult to control, because when they eat, the food doesn't get absorbed into the bloodstream, and so they can be very, very difficult diabetics, very brittle diabetics. The third important group are the post-surgical. People who've had fundoplication, had intervention at the esophagus, achalasia of the cardia that's been operated on by something called a Heller's myotomy. Any intervention at where the esophagus meets the stomach is very close to the vagus nerve, and the vagus nerve controls the motility of the stomach. So if you damage the vagus nerve in any way, you'll get gastroparesis. And then there are 10% of my patients will have other rare conditions such as associated connective tissue disorders. So there are the rare bunch, but the vast majority will be hypermobile patients, diabetics, and post-surgical patients. And remember, some of the commonly used drugs like the GLP-1 agonists that everybody's now taking for weight loss basically induces gastroparesis. That's how they work. So they slow down the stomach, you stop feeling hungry, you feel nauseous. So beware of the patients on the GLP-1 agonist. They'll have mild symptoms of gastroparesis. And some of the other medication we use, such as antipsychotic medication, will have anticholinergic properties and will cause delayed gastric emptying. Next slide, please. What are the treatment options? Well, you'll hear about lifestyle modification shortly from our dietitians. But what we're trying to do is create an algorithm, a treatment algorithm for patients with gastroparesis. So if they're severe enough to come and see a specialist, then we do the gold standard, which is a gastric emptying study. There are some that are widely available, such as the nuclear medicine radionuclide scans, but others, the breath test is less available, but more reliable in my experience. But we get a breath test so that we can actually confirm these patients have gastroparesis. And when they see that number in front of them, the tears come out, everybody's a sigh of relief, because these patients have been telling their GPs, have been telling their specialists for years and years and years, this is what I have. And now we have proof that this is what they have. So we then start treatment, and the treatment is like a stepladder approach. It's an algorithmic approach where we start with prokinetics, and every one of us has different receptors in their stomachs that respond to different chemicals. So you need to try the different prokinetics to know which ones, if any, work for you. So it's very important that you've tried all of these prokinetics like domperidone, metoclopramide, and low-dose erythromycin, because you might respond really well to one, but not necessarily to the other two, or you might respond to two, but not the third. And it's important to know that if you use a prokinetic for very long, your body becomes used to it. You develop what's called tachyphylaxis. So it's important to alternate and use them cyclically rather than continuously for long periods of time. If prokinetics don't work, we can do something really simple like do a trial of intrapyloric Botox. And that's done at endoscopy with sedation as a day case. Safe as houses. We inject Botox into the pylorus, which is the muscle at the end of the stomach. Because one of the problems that causes delayed gastric emptying is that the stomach is not squeezing hard enough, so it doesn't trigger relaxation of the pylorus, which is like a sphincter, a tight muscle at the end of the stomach. So if the sphincter doesn't relax when the stomach squeezes, then that will be contributing to the delayed gastric emptying. So what do? We inject Botox into the pylorus, and that paralyzes the pylorus. And then we see you again after 6 weeks, and we see if you improve. If you improve after Botox, we don't repeat the injections, because if you keep repeating the Botox injections, you get scarring at the pylorus. So we then put you forward for a permanent pyloric modifying procedure. In my experience, a balloon pyloroplasty works best. It's safe, it's easily done, it's done with screening, and you don't need to do the G-POEM. There are other centers that are real advocates of G-POEM. It depends on who you see at the time, but that might be the alternative. But the end result is that by the end of that procedure, you've completely torn open the pylorus, so it's a permanent form of Botox. And if the Botox worked for you, then the pyloroplasty will work for you, and that will be permanent. If Botox doesn't work, then what we do next is give you a trial of nasojejunal feeding. And what you're doing is bypassing the stomach to see that if you bypass the stomach and feed directly into the jejunum, does that solve your problems? And the reason we do this is because what we're trying to do is decide whether you're suitable or not suitable for a gastric electrical neurostimulator. Now, some of you may have heard of gastric electrical pacemakers or neurostimulators. Some of you may not be familiar with them. And they were invented by Medtronics, who make the cardiac pacemakers, over 20 years ago. And when they first came out, there was this huge wave of excitement. Everybody got gastric pacemakers. Some did extremely well. Some patients with gastroparesis did extremely well, but equally, half of the patients did really badly. So that gave gastric pacemakers a really bad name. And so when we look back on the data, we realize that what you have to do is you have to choose your patients very carefully. And that's why we do the trial of nasojejunal feeding. Because if your motility disorder extends to your small bowel and to your colon, then bypassing the stomach is merely kicking the can down the road. And what you need to know is that if you fix the stomach, will the small bowel and the colon cope with that? And will you feel better or worse? And if you feel better on a trial of nasojejunal feeding, it means you are suitable for a pacemaker. And it is the ones that respond positively to nasojejunal feeding that we offer the stimulator to. If you feel worse with the nasojejunal feeding, then you are not suitable for a stimulator, for a pacemaker. And in those patients, we offer them a PEG with a jejunal extension, which is a direct communication to your stomach, and then a tube inside that going beyond the stomach in through the pylorus into the jejunum, so that we can feed you into the small bowel at a controlled rate. And this is very important, at the same time, decompress the stomach, vent the stomach to allow these patients to feel better. So that what I'm trying to get across in a very short time, and I know my time's run out, is that we've got lots of things that we can do. And if we put these things in a nice, clear algorithm for patients, we can help patients.
Thank you so much, Ray.
I'm sorry I ran late.
That is okay. I think people will be glad to hear from you, so I will forgive you for running late. Don't worry. Thank you so much. So now we know a bit more about what gastroparesis is and the kind of medical treatment options. We're going to hear a little bit from Beth Hallam. Beth is an upper GI specialist gastroenterology dietitian with over 20 years experience working both in the NHS and freelance. Beth has extensive experience in gastroenterology, but I know a special kind of passion and interest in gastroparesis. Beth, all yours.
Oh, thank you very much. Can you hear me okay? Excellent. Thank you. Yeah, thank you very much for the introduction, and a really big thank you to Guts UK for asking me to speak today and to join you all. So before we consider diet, there are several lifestyle factors which can really affect people with gastroparesis. There's evidence that smoking can really impair that gastric motility and reduce that gastric emptying. And it's quite possible that some of that's driven by the nicotine in cigarette smoke. So it's also possible that things like vaping may have similar effects, though I've not yet seen any real clear evidence for that. Alcohol and fizzy drinks may exacerbate symptoms, particularly those of bloating and nausea, and likewise reducing caffeine and choosing decaf options or alternative fluids can help to manage those symptoms. So thinking a little bit about posture, being upright whilst eating just allows gravity to really support that gastric emptying, whereas being slumped or lying down or not sitting in that upright position can really contribute to a slower gastric emptying. And I think the way that we eat also plays a really big part. So making sure that we chew our food really well, eat really slowly, and allow time for our stomach to empty as much as possible might help those symptoms. And whilst it's really easy to say and not so easy to do, reducing anxiety and stress by whatever means work for you as an individual can be really helpful. So it might be mindfulness, it might be meditation, and it might be gentle exercise. So what are our dietary goals in gastroparesis? Well, predominantly, we want to try and avoid malnutrition and maintain a good nutritional status. And that's obviously at high risk if people have pain on eating or vomiting. And a dietitian should also ensure that any dietary interventions are avoiding vitamin and mineral deficiency, and also monitor symptoms with a real goal of some symptomatic improvement. And if there is an underlying cause for gastroparesis, such as diabetes, then diet might play a role there in terms of blood sugar management, which we call glycemic control. So good glycemic control can help to improve that gastric emptying. So the first thing that we need to undertake in a nutritional assessment is a measurement of weight, height, and body mass index. And nutritional assessment shouldn't be limited to these. So body mass index is weight in kilos divided by height in meters squared. A BMI of under 20 would put you in the underweight category. 20 to 25 would be considered healthy. 26 to 30 would be overweight. And 31 and above would be obese. But in practice, what we see is that all shapes and sizes of people are diagnosed with gastroparesis. And quite often more important than weight is and body mass index is that weight change over time. So has weight been stable despite symptoms, or has weight been declining slowly? So a 5 to 10% weight loss would be an early indicator of undernutrition, and greater than 10% weight loss would become clinically significant. And it's worth being aware that you can be overweight and yet clinically malnourished if you meet those criteria. So diet recall or a diet history is just a picture of your usual intake and a real chance for your dietitian to evaluate your preferences, the main sources of nutrition in your diet, dietary patterns, and link those to the symptoms that you suffer from. And if, for example, you have large volume, frequent vomiting, then there's a much higher risk of a rapidly declining nutritional status. Whereas if the predominant symptoms pain and bloating, but your intake's reasonable and your vomiting's rare, then it does indicate that your stomach is likely to be emptying enough to maintain nutritional status with an oral intervention alone. I think we've already covered lifestyle strategies, but micronutrient levels are also important, and these can be checked with a blood test. So a full nutritional screen would be indicated if somebody's lost significant weight or has a low body mass index. So initially, we would start with oral dietary changes. But being able to eat and drink orally is so important, even if what you eat and drink has to be modified, because it isn't just about getting the nourishment that you require. It's also a social and psychological element to it. And some of the guidance that we've got suggests that we should use these oral strategies for 2 to 3 months to see if they're effective first. So this diagram shows some of the strategies that might be explored to help manage symptoms. And for some people, it's as simple as trying to have a small and frequent meal plan. So trying to have 4 to 6 small meals per day rather than 1 or 2 bigger meals. It might be that texture modifications, such as a soft or moist or pureed consistency, is better tolerated, and we tend to call this a smaller particle size diet. And we know that some food groups like fat and fibre often sit in the stomach for longer. So some people get symptomatic improvement when they reduce the fat and the fibre. I think we've covered carbonated beverages, fizzy drinks particularly can really aggravate that distension. And it may be really important to think about increasing high calorie liquids or high protein liquids or liquidizing meals. I think we've covered vitamins and minerals as well. So people with gastroparesis often ask if there are specific foods that they should avoid. And this can be really individual, and it depends upon how that food is cooked and served. So an example might include broccoli, which served undercooked and whole with a meal might cause significant symptoms, but if overcooked and liquidized in a soup, might be better tolerated. And there is one study in the literature looking at this, but it considered only a really small sample size of individuals. But it did identify that fatty, spicy, and roughage-based foods were the hardest to tolerate. I think it's really important to avoid excluding specific foods altogether, because this could have a really negative impact upon nutritional status. So really important to check with your dietitian that you aren't compromising on that nutritional adequacy. So tube feeding, I know we've briefly touched upon this already, but let's have a little think about this. So should you have implemented all the medical, dietary and lifestyle interventions and nutritional status continues to decline, or your healthcare team want to consider trying this to see if other interventions are appropriate, then there is the option of tube feeding. It's usually initially via the nasojejunal tube, as Dr. Shidrawi has already explained. So a tube that is passed up your nose, down your gullet, through your stomach and beyond, so that the tip of the tube lies in that upper part of your bowel called the jejunum. And because this bypasses the stomach, it can be a really useful means by which nutrients and fluids can be delivered into the body without exacerbating those symptoms. And if this method is successful or well tolerated and other treatment options aren't available, your healthcare team may consider progression to a more permanent feeding tube, such as a jejunostomy. So that usually does require surgery and can be placed in theatre, and it's a small tube that sits on the surface of the abdomen and is inserted directly into the loop of small bowel, a loop of jejunum, and anchored there. But both nasojejunal feeding and jejunostomy feeding usually do require a hospital admission in order to establish feeding. And in some very rare cases, jejunal feeding is poorly tolerated and nutritional status can continue to decline. And if the small bowel is proven to be failing, it may be necessary to feed somebody intravenously in order to stabilise nutritional status. So this would be a careful decision made by a number of different hospital teams, and it's a much higher risk way of feeding people. So thinking about dietary management, this diagram summarises the dietary intervention pathways that we consider. And I was careful to use the word management rather than treatment here, because I feel that diet is a real adjunctive therapy to the medical treatment. The term treatment does imply an intervention that treats or reverses the causes of gastroparesis, whereas diet really is a means of supporting or managing the effects of the condition, the effects being the symptoms and that change in nutritional status. So hopefully we've covered the ways in which a dietitian might contribute to the management of gastroparesis. There are various ways that you can access a dietitian depending upon your circumstances. So if you are under the care of a specialist doctor or a surgeon, then you should be able to be referred to a specialist dietitian. Equally, your general practitioner following diagnosis could also refer to a community dietitian. In some circumstances, if you don't meet the criteria for NHS dietetic services, then you can access private dietitians, which you might be covered to see by healthcare insurance or can self-fund, and you can source private dietitians via the link contained here. So, in conclusion, gastroparesis management really should include medication, lifestyle, and diet. And I think, just to reiterate, it requires really skilled communication from knowledgeable healthcare professionals, and a multidisciplinary approach to the management is particularly important, especially when we're thinking about tube feeding. And finally, and perhaps most importantly, it's a condition that can impact hugely upon people's quality of life. And I think it's so important that you seek information and support, such as from Guts UK, if you're living with this condition. Thank you.
Thank you so much, Beth. Thank you for joining us and sharing all that. I think really helpful for people to, as you say, understand how to manage rather than necessarily treat gastroparesis. So thank you. Our next session, we feature two of our experts who are living with gastroparesis. So thank you very much to Sadila and Michael for joining us. Sadila Hussain is a counsellor in the NHS who is passionate about supporting people who are going through their own gastroparesis journey, and is a very proud and very good speaker about her own experience, and loves to support and nurture people who need it going through their gastroparesis journey. And Michael Gregg is actually one of our Guts UK's panel of experts by experience, who help to ensure our charity does what we can to actually represent the patient voice and focuses our attention where it's needed. Michael also does a lot of freelance work supporting charities and organisations to ensure their inclusion policies are fit for purpose, and he represents the patient voice in a lot of medical research groups and focus groups. So thank you both for joining us. What I think we'll start with is a little bit about your symptoms. So I'd love to hear from both of you. What symptoms did you first present with, and how long did it take you to seek help? Michael, why don't we start with you?
I started experiencing vomiting, regurgitation, reflux, heartburn, distension and pain in about September, October 2014, just as I started at university. I then saw my GP in the December/January. I then had a fundoplication in December 2015, and my symptoms returned within about 4 months. At this point, I sought the earliest appointment I could get and was then referred for another endoscopy.
Thank you, Michael. And Sadila, how about you?
So my symptoms started in 2011. So I was 21 at the time, and like Michael, I was at university as well, doing my finals. And just started vomiting all the time. So wasn't able to keep water down up to 12 to 20 times a day. I went to the GP straight away. They thought it was food poisoning. When it was still continuing, they thought it was stress because I was doing my finals. When it wasn't going away, and I was going to the GP every week, basically, for a couple of months. They then referred me to a gastroenterologist. But I think I was going back and forth to the GP for 6 months, and they tried multiple medications, and nothing was helping. So then they referred me to a gastroenterologist for further testing.
Thank you. There is an inadvertent theme here about university that we won't go into. So we'll move on to talking about your diagnosis, if you don't mind. So it'd be great to hear how long it took to get your diagnosis and how it was diagnosed. Sadila, do you want to go first?
So my symptoms were this bloating pain, feeling full after eating, and then vomiting. So I could vomit half an hour after eating and then 18 hours after eating, and the food still wouldn't have digested. When I was referred to a gastroenterologist, I tried multiple medications. I think I had 4 endoscopies, CT scans, ultrasounds, X-rays, dietitians. I got every diet you could try. I tried, and I tried they said they couldn't find anything, so they said it was IBS. Sent me for mindfulness for IBS. At one point said, "Oh, you're depressed. Maybe you want to try some antidepressants." To which I was like, "No, I'm frustrated, and I'd like you to do your job." I think that's what I said back to my consultant. And she discharged me, so I went private. And when I got my private notes, she said she thought it was all in my head, or I had an eating disorder. So I sought a private consultation, and in the private consultation, they suggested having a gastric emptying study, which they put me forward for. And when I had the gastric emptying study, after 4 hours of scans, they said that nothing had digested at all. And then they said go back to your gastroenterologist for further testing for and further treatment. So I had the Botox, and that was not successful either. And then I was referred on further to have the gastroelectric neurostimulator. So all in all, about 2.5 years to get a diagnosis.
Quite a long journey for you, Sedila. Thank you for sharing. Michael, how about you? How long and what was your journey to diagnosis?
My journey followed on from that endoscopy because it showed my stomach was full of food after being nil by mouth for more than 8 hours. After a bit of querying on the day, my gastroenterologist suspected something else was up. I then had a gastric emptying study within a couple of months and received a gastroparesis diagnosis a few weeks after that. During diagnosis, I was seen through insurance provided by my dad's work at the time, which I haven't been for about 6 years.
Thanks, Michael. What I'd love to hear about next is kind of your current treatment. I will caveat before we go into this that there are a number of different treatment options available, and appropriateness and availability will vary depending on kind of your symptoms, your condition, and your location. So what works for Sedila and Michael may not necessarily work for everybody else. But I'd love to hear about your current treatment. Michael, why don't you go first?
I take a range of medications, so most of the prescribable medications I take at the highest dose. I take medications or treatment that are used for treating nausea, reducing acid, reducing wind, helping with generalized GI discomfort, helping accelerate or empty my bowels, and medications to help with gastric emptying. I also eat a soft diet, avoid foods high in fiber and fat. I don't drink alcohol or fizzy drinks. I sometimes eat purees and or liquids such as soup, and I eat about 5 to 6 times a day, including snacks. I have also previously seen a dietitian. But other than that, more recently, my consultant at the time focused on treating my reflux rather than my gastroparesis. This led to a suggestion of a redo of my anti-reflux surgery, which I couldn't go through with. Due to this, most of my treatment is focused on managing flares as and when they come. This can involve hospital trips for IV anti-sickness and fluids. It also involves me doing lots of work to try and stop it, including reducing work commitments where possible during these times and focusing on reducing stress.
Thank you, Michael. Sedila, I know you've got a very different treatment plan. I'd love to hear about yours as well.
So I had a gastric electrical neurostimulator.
Sorry,
It's a
making
bit of
you
a
say it again.
mouthful.
Sorry.
I had the device fitted in 2013, and I saw my symptoms reduce dramatically quite quickly within 6 weeks. Within 6 weeks, I think I was vomiting once a week. So I went from 20 times a day to once a week within 6 weeks. So I saw quite a significant difference. The longest I've gone without having any symptoms is 9 months. And I go back to my consultant every 3 weeks, no, 3 weeks, 3 months, for just any of my settings to be adjusted. And I had the device changed and replanted, the batteries changed in 2021. So I'm on my second device, and I saw the benefits of it because my battery started to run out during the pandemic. And when it did, all my symptoms returned. So I saw the difference on where my treatment had worked for me, and then when the new battery was put in, all my symptoms improved. So for me, that treatment plan worked. I also then do take medication for anti-sickness and reflux as and when I need to. So and then stomach pain as well, and then just changing my diet when I'm in a flare up as well.
Super. Thank you, Sedila. So for both of you then, thinking about your experience with diagnosis and treatment, do you have any tips for someone who's partway through their journey? What might you advise somebody who's going through diagnosis or coming into the start of their treatment? Michael, can I come to you first?
Based on my experience being early in education, especially at university. Someone's just put the kettle on. So if you are in education, I would suggest that people gather what they can, such as appointment letters, confirmation of testing letters, summary of emergency admissions letters, and potentially even consultant to GP letters in case they need to get further support down the line, so that you don't have to rush it later when you may be at your worst.
Thanks, Michael. So planning a little in advance and pre-preparing for potentially when your flare-ups are worse and you need to be prepared. Thank you. And Sadila, what about you? Any tips?
Say kind of keeping logs. So keeping like a food diary, keeping logs of like pain logs or sickness logs, because sometimes you might go into an appointment and say, well, keep a log and come back in 3 months' time. So at least you're already ahead of the game and you're already going in there prepared and saying, I've already got a log of this is what I've tried already, and this is what my symptoms are like on certain days. And making notes. So even if your family have got questions, just take those questions into those appointments. So you can get those answered, and making notes in those appointments, because sometimes you might go into those appointments and everything feels quite overwhelming and you might feel quite anxious in those appointments when you don't remember anything that's been said in those appointments either. And also not being afraid to kind of ask if you need some mental health support during it either, because living with a chronic illness is going to be difficult and it might be quite anxiety, might cause you anxiety. So asking for support is there's nothing wrong with that either. It's a big change that's happened in your life that you're not in control of.
Thank you. It's a really good point, Steve. Thank you for sharing that. So I'd love to hear as well, changing tack slightly, what does day-to-day life look like for you at the moment, Sadila?
At the moment, I'm relatively stable with my gastroparesis. I work in the NHS. I'm a qualified psychotherapist and I manage a mental health service. And it's quite different to when I was going through my diagnosis, where I didn't really have a quality of life, where you couldn't work, you struggled to go out with friends, you didn't go out with friends because you didn't want to go out for a meal, and you really did not have a quality of life. And I really saw that change during the pandemic when all my symptoms returned and I had that experience of what it'd been like to be well and it was taken away again. So for me right now, it's being able to go out for dinner, having those social relationships, not having to worry about, is this going to cause me a flare up? Where's the nearest toilet? Am I going to be sick? And not having to worry about those things. And I think it's also just being aware of, like, people might have heard of like the spoon theory, where how many spoons have you got? So if people have got chronic illness, it's just that theory of how much energy can you conserve. So if someone who's quite healthy might have a limited unlimited amount of spoons, but if you've got a chronic illness, then you've probably got only 12 spoons, and it might take 4 of those spoons just to get up and get dressed. And actually, to make a meal is going to be another 4 spoons, and you actually don't have the energy to do anything else with the rest of your day. So sometimes I think it's about conserving your energy as well.
Thank you, Sadila. And Michael, kind of similar, what does day-to-day life look like for you, or how many spoons do you have at the moment?
With regards to spoons, I only have a few and I'm using majority of them to be here.
Which we appreciate, thank you.
At the minute, I am in a flare that has lasted over 2.5 months, and it's the worst it has ever been for me consistently. This can involve vomiting up to 80 plus times a day. It can also involve bringing up food 28 hours after eating it. Even when not in flare, I experience symptoms every day, but am now usually flaring for the majority of the year. I experience nondescript pain, and there are multiple days where I struggle to keep down much food and solids at all. An average day, I get up, take medication, then wait for a meal. If I have a meeting for, say, a research project where I'm a public partner, I'll join that from home. I will then have a small meal, a bite to eat, or a nutritious drink, and this will repeat throughout the day potentially, depending on how busy I am. But even attending all those meetings from home is incredibly difficult at the moment. I sometimes need to travel to support an access related project, but keep that to a minimum as that takes a lot out of me. To relax, I may game, read, go say hello to the neighbours' cats that visit, go to the cinema or theatre if I am able to handle the travel.
Thank you, Michael. And I will reiterate our thanks for both of you for being here, because this is a big ask, and we're not talking about how many people are here, but it's a big ask and it's a presentation from a number of people. So thank you. And for those actually on the webinar, for those people who are here, perhaps supporting their friends and family who have gastroparesis, it'd be nice to hear from you guys. What would you like them to know about living with gastroparesis that perhaps isn't obvious? So what might people's friends and family want to know? Michael, let's come to you first.
For me, it would be the fatigue that you can experience, especially when the vomiting can be incredibly forceful for me. It can be incredibly draining. For me, there may be weeks or months at a time where I cannot do much at all, but it can also be quite variable, because one day I might not manage much, and then a few days later I might be able to manage an all-day meeting at home. So I would say pay attention to the fatigue, especially as I may have brushed it off early on as I was starting at uni at the time, and may have thought that it was a long freshers flu.
Thank you, Michael. And Sadila, how about you?
I think just being patient and listening. Sometimes words of encouragement, like, why don't you try that? Or why don't you try this? It's not sometimes always helpful. People probably trying their hardest that they can. And also taking your friends or your family members' lead, like it's their body, they know what they can do, and what is in their control. And also at the same time, not isolating them. They may not want to go, but they still might want to be invited. So it's that impact that it might have on them as well.
Thank you. I think really useful advice. A bit of patience, a bit of understanding of the fact that things might be up and down, and that the people living with gastroparesis know their body and their condition best. Thank you both. I think we're gonna stick in this advice sphere now, and we're gonna stick to kind of what you would say to people. So what would you say to somebody who is at the beginning of their journey right now? So somebody who is maybe not yet diagnosed or close to diagnosis, what would you say to the Sadila or the Michael who's back at university? Michael, let's come to you first.
I think for me, it would be put in the work now and start reaching out and start building a support network around you. It's about starting to build those strong relationships to weather how tough this condition can be. And it's also great when that allows you to meet people you don't have to explain the condition to, and can discuss how bad this can be sometimes.
Thanks, Michael. Really good advice. And Sadila, anything from you?
I think listening to your body, you know your body best. You know when something's not right, and having to advocate for yourself. And don't be scared to get a second opinion. If I never got a second opinion, I wouldn't have had my diagnosis. And don't be afraid to ask and challenge.
Fantastic. Thank you. And I really think there's some great tips there you've both shared for people to take forward. Not only just knowing how many spoons you've got, which I will definitely take forward with me. So genuinely thank you both for sharing your time and your experience with us today. I'm conscious a little bit of time, I think because I've spoken too much, not you, Ray, to be honest. So we will open up for a few questions. As I said at the beginning, they are moderated. So we've got Julie from the Guts team who's going to field the questions. We may only have time for a few, so we will make sure we store up all those questions and we try and answer some of them separately after the webinar. So if we don't come to your question, I apologise. Julie, I can't see you, but I'm going to let you pop up with questions.
Hi, everyone. And thank you so much for all your questions. There's lots of them, and they're really, really interesting questions as well. So if I could start with Dr. Shidwari, there are quite a few questions. So one of the first ones is a question. I believe gastroparesis is caused by Toxoplasma gondii. Do you think this might be the case?
So a lot of so we were talking about the commonest group, the biggest group that I see with gastroparesis belonging to the hypermobile variant of Ehlers-Danlos syndrome. there are a lot of people out there with EDS, with Ehlers-Danlos loss, but not all of them have gastroparesis. And the recurrent theme when I see patients who have Ehlers-Danlos loss, who've developed gastroparesis, is there's usually an environmental trigger that sets off this whole thing and sets off the cascade of symptoms that's eventually diagnosed as gastroparesis. And whether that's COVID, we saw a lot of patients after COVID, whether it's a really nasty bout of gastroparesis, gastroenteritis, people traveling abroad, catching really nasty dysentery in Thailand, in India, or in South America. So whether it's an infection, and I have seen it come on after a infectious disease. So I had one lady came who'd been traveling around Africa, and she'd caught the most bizarre parasite, and that parasitic infection triggered the whole thing on her. So I think the toxoplasma theory is possibly very, very likely, but the point is that it's often an environmental trigger, often in the form of an infection, that sets off this whole thing in genetically susceptible individuals.
Thank you for that. Right, so there is one here for Beth. Just bear with me. Problem. How long can patients remain on nasojejunal feeding?
Yeah, so you know, in theory, it should be a couple of months, maybe 2 or 3 months. Different tubes have slightly different protocols and policies with regard to replacement. But quite frequently in numerous different trusts across the country that I've worked within, our policy for nasojejunal feeding tubes would be that we would use them for as long as they are intact and in the correct position, because placement of those tubes isn't easy. So it's an X-ray or it's an endoscopy. So if they're working and they're in the right place, we will often push them past those couple of months. But the bigger question is, do we need to be thinking about a longer term feeding solution? So at that point, if there isn't the option of the gastric stimulator, would we be thinking about whether a surgical jejunostomy or a PEG with a jejunal extension is the next appropriate thing to consider? Does that answer that?
Yes, thank you.
Thank you.
And just some feedback to Cedilla and Michael. There's a comment that excellent ways to deal with gastroparesis, both of you. And if you would like to share, and you don't have to do this at all, how do you feel when you were given the diagnosis of gastroparesis? Shall we go to Cedilla first?
I was grateful that it wasn't all in my head, and there was actually there's something wrong with me. I know that sounds really odd to say, but I was just finding like I knew deep down it was an IBS. I knew deep down that it wasn't in my head. So I was like, actually, I just then needed to figure out how can I find a cure? I realized there was no cure, but then it was like, okay, how do we work on treating this? But I was just relieved that I had a diagnosis. I think there's just a huge sense of relief to have a diagnosis.
Understandable. Michael, are you happy to share?
I think for me, it was a sense of overwhelming relief that we'd finally found what was going on. And then, because I was studying anatomy at the time, I just was like, right, now my research work begins.
Yes. Thank you both so much. I think we've got time for maybe another question, Katie.
Yeah, one more at least, yeah.
Okay. Lots to choose from. So again, one for Dr. Shudwari. If someone suggests GLP-1 antagonists, but one already has gastroparesis, you would not recommend it even if BMI and comorbidities are high? Am I correct with that?
So people with underlying gastroparesis, if you give them a GLP-1 agonist, they're going to feel a lot worse. No doubt about it. And it can, have a very prolonged effect even when you stop the GLP-1 agonist. So I've seen patients with mild gastroparesis start a GLP-1 agonist and then felt so rough for months afterwards, and it seemed to have just tipped them over the edge. So definitely not one for you. There are other options for managing your weight, and you should always take advice for an alternative. It's very easy to jump onto that bandwagon that everybody's getting on, and in some situations they're very helpful. But in patients with gastroparesis, I would strongly advise you not to take GLP-1 agonists.
Thank you.
Thanks, Ray. And there are a number of questions that I will take, even though I said I wasn't the expert, about whether or not we're recording this session. So yes, we are. This is being recorded, and it will be available on our website after the event. So that you will be able to share with friends, family, or anybody that missed it. So it is being recorded. What we will also do, given the volume of questions we've received and the little time we have, is we'll take all those questions, and where we can, we will answer those in an FAQ document on the website as well. With that, I will do a final thank you to Sadila, to Michael, to Beth, to Ray, and to Julie, our question master. Thank you all for joining us, sharing your evening and sharing your questions, which, as I say, if we haven't covered it, I apologise. We will make sure we try and take those all into an FAQ document on our website. There is now a QR code on your screen. I would ask either using the QR code. I appreciate some of you may be on phones, so can't, and we'll also email out a link afterwards. If you can spend a few minutes either through the QR code or link in the email doing feedback for us. As I said, this kind of online webinar is a new thing for Guts UK Charity to do, so great if you can share some feedback about how you found it today. Both the link and that QR code also have a direct link to the Guts UK information on gastroparesis, where you can look and get more information. And there's also wider information on the website, and you can contact us directly if perhaps you haven't raised a question or something else comes up. So I think that's it from all of us. As I say, thank you all for spending your evening with us, and I really hope you've learned a little bit more about gastroparesis this evening. Thank you so much.